Hello, everyone. Thank you for tuning into this session, Introduction to Prostate Cancer and Primary Treatment Options. My name is Jenna. I am the Program Coordinator for the Prostate Cancer Supportive Care Program. And I'm joined by Dr. Ahmad Almarzouq and Dr. Katie Jasper, who will both be talking about the different treatment options available for prostate cancer patients in British Columbia. Before we get started, I'd like to just acknowledge some of the groups that have made our program possible. And so back in 2013, our program was created at the Vancouver Prostate Centre. And we did that by using seed funding that we received from the Specialist Services Committee, which is a joint collaboration between the BC Ministry of Health and the Doctors of BC. Over the years, we've partnered very closely with BC Cancer and the Prostate Cancer Foundation of BC to expand the reach of our program so that more prostate cancer patients across the province could access our program. And of course, we're very grateful for the philanthropic donations that are made by individuals to our program. So first of all, what is the Prostate Cancer Supportive Care Program? Well, we're a comprehensive survivorship program that's designed to help patients and their partners and family members from the point of diagnosis onwards. And so in order to do that, we have 7 different modules, and each of these modules have a different topic or theme related to the prostate cancer experience. And so later on in this presentation, I'll be talking a bit more in depth about what is included in each of these modules and how they can help support you later on. And just a little overview of what we'll be going over today. The presentation will start off by going over the anatomy of the prostate and prostate cancer. And then the physicians will talk about the different treatment options for prostate cancer, including radiation and surgery. And then, of course, I will talk more about the modules in our program and how they can support you during and after treatment. So that being said, I'd like to pass it on to Dr. Almarzouq.
Hello, everyone. My name is Dr. Ahmad Almarzouq. I'm one of the Uro-Oncology Fellows here in the Vancouver Prostate Centre. I will be giving you a talk today, or part of the talk, in the first module in the Prostate Cancer Support Center program. And I'm sure most of you have gone through your diagnosis process and are coming here for more information. You've probably discussed your treatment options as well. And we will go over a little bit of background information about the prostate, the diagnosis of cancer, and the treatment options afterwards. So we'll start off with basic background things. So where is the prostate located? The prostate is located deep in every man's pelvis. It lies below the bladder, in front of the rectum, behind the pubic bone, and it wraps around or surrounds the urethra, which is your urinary channel that communicates your urine from the bladder to the outside world. So some facts about prostate cancer. It's a very common disease in men. About 1 in 9 men have it in their lifetime. It is, in general, a slow-growing disease. Most of them can become more serious over time. However, the survival rate is nearly 100% for cancer that remains localized within the prostate and has not spread outside. There are some risk factors that increases the likelihood of having a diagnosis of prostate cancer, and these include the age. So the older men are, the more likely they are to have prostate cancer. Race. Research has found that individuals of Black ethnicity have a higher likelihood of developing it compared to their Caucasian counterparts. And similarly, both were found to have a higher incidence compared to their Asian counterparts. Also, family history is an important predictor or factor in this, or a risk factor rather. And family history of prostate cancer or any other cancers is important to disclose to your doctor, your treating urologist or treating physician. At this point, I would imagine the majority, if not all of you, have come across the PSA test. And essentially what PSA stands for is prostate-specific antigen. It's a normal enzyme made by the prostate gland, and it normally liquefies the seminal fluid, which comes out with the ejaculate. and it is important for fertility. It is present in the bloodstream, and this is how we detect it in blood tests. So how do we use it? Usually we use it in combination with a digital rectal exam, and this combination helps us to screen for prostate cancer. But does any increase in the PSA value mean you have cancer? Absolutely not. Other conditions can contribute to that, or can cause the PSA to increase, things such as infection, trauma, and benign enlargement of the prostate, which is very common among men in the risk group for prostate cancer anyways. And when compared to screening for cancer, the PSA also has another role, which is it's a reliable test after men are diagnosed to keep following the disease, and men who were treated for their prostate cancer. For example, after surgery, PSA should be undetectable, and after radiation, PSA may be undetectable or very low, but we want it to be stable. Any changes in these values can prompt further investigations after treatment. So, is PSA the only thing we use for diagnosis? Absolutely not. There are other things involved in your journey through a diagnosis of prostate cancer. And obviously, once you have the biopsy done, which is prompted by the PSA and the rectal exam, the stage of the disease is an important piece of information. The GLEASON group, which is when our colleagues in pathology analyze the specimen taken in the pathology under the microscope, and the PSA value. There are other things such as the Capra score, which are very good at predicting the risk of disease relapse. These are very smart calculators, or what we call nomograms, that take all the information in and through a complex algorithm are able to produce a number which reflects the risk of the disease coming back. We'll start a little talking about the tumor stage. So the T stage, T indicates the stage and the number is how advanced the disease. It goes from T1 to T4. Obviously, the higher the number, the more advanced the disease. T1 disease means that it was not picked up with clinical examination. It was a PSA that prompted either a biopsy, and occasionally it can be picked up in other prostate surgeries. T2 means that the disease is detectable or picked up during clinical examination. T3 can mean that the disease has spread just outside the prostate, where you can feel it on the capsule of the prostate with the finger. And T4 means this disease has spread or is locally advanced, which means it's felt elsewhere outside the prostate on clinical examination. The GLEASON score, GLEASON grade, or group grade, or grade group, you'll hear all these terms, which can be on occasions confusing. I'll try to give you a very quick rundown of what the GLEASON score means, but then I'll show you that we've moved away from that when talking to patients, and we've simplified it into a different scoring system. So the GLEASON group usually reflects what the pathologists see under the microscope. They're able to see the tissue under the microscope, and the closer the resemblance is to normal tissue, the lower the grade, and the further or the less the resemblance is in the suspected or the cancerous tissue from normal tissue, the higher the score. And then the most common two scores found on the examination are combined together and gives us the GLEASON score. So you'll hear a lot of urologists telling you have a GLEASON 6 disease or GLEASON 7. Occasionally they'll tell you things like GLEASON 3+4. And what that reflects is what the pathologists see under the microscope. And we've gone together as a community and we've tried to simplify this just for the sake of conversation with patients, because the numbers seem to confuse even some urologists or physicians that don't work in the prostate cancer field. So we've gotten all these numbers and we've grouped them together in a grade group or different categories. The grade groups go from 1 to 5, and they reflect the different grade groups, or the different GLEASON scores rather. We see here grade group 1, which is historically has been GLEASON group 6 or GLEASON 6 score. And the higher we go up in the grade group, the higher the GLEASON score is, reaching GLEASON 9 and 10, which is grade group 5. And this reflects advanced disease. And you can see here on the diagram on the right, the probability of the PSA remaining undetectable after surgery. So in the grade group 5, there's a high chance that the PSA will remain high after surgery, which may need a second line of treatment. The pathologist doesn't only give us this information, they also give us the number of cores that came back showing cancer, the percentage of cancer in each of these cores or needles, and the location of each positive core. Occasionally, men have disease on one side of the prostate, but not the other. And that can be helpful information for surgeons, for instance, to plan their surgery and plan what we call a nerve snare, which we will get into a little bit further down the talk. And when put together, these details can also help define the risk of the disease coming back. We've kind of grouped patients based on these elements that we discussed into risk groups. And the risk here sounds like a scary word. This does not mean risk of death from disease. In fact, it does not mean death from the disease. It just means the risk of the disease coming back after surgery. We've summarized the risk groups. Obviously, there's different types of breaking down these risk groups, but I believe this table is quite comprehensive in encompassing all these risk groups. We have risk groups that go from very low to very high. The highest group, meaning there's a very high risk of the disease coming back. The combination of the T-stage, grade group, and the PSA put together usually gives us whether the patient has a risk, high or low risk or intermediate risk of the disease relapsing after treatment. So for instance, the very low and low risk, as we can see, the grade group is grade group 1, and these are rarely felt on examination. And in terms of their treatment options, active surveillance, surgery, and radiation are all equivalent here. In fact, we generally recommend active surveillance for these patients, so no intervention. When we move to intermediate, which is a higher grade group, a higher stage, and certainly a higher PSA, this would put the patient in a category where we would be recommending surgery or radiation. Active surveillance become a lesser option or an inferior option to the other two. And then we move into high and very high risk, which again, looking at these three factors, the T-stage, grade group, and PSA, the PSA would have to be higher than 20, and the grade group would have to be 4 or 5, and the stage on examination would have to be high as well. And in those cases, we recommend surgery or radiation. Occasionally, we may have to use what we call a multimodal approach. So we'd start with one treatment, and then based on the PSA after treatment, we'd be adding a second line of treatment. It is important to point out that what we're talking about today is localized prostate cancer, so disease that remains within the prostate and has not spread out. The importance of emphasizing this is because disease that is localized is very much treatable, very high chance of cure, and in most men, this is a slow-growing disease. So when you get your diagnosis, you should not be rushing to having the treatment done within 2 weeks, and this should not be a source of anxiety to you. This allows you time. Your diagnosis allows you time to choose what treatment strategy you feel you can cope with afterwards. It allows you to seek the opinion of urology, radiation, and do your own research. Moving on, I will talk about the treatment options for localized prostate cancer. My part of the talk will include active surveillance and prostatectomy. Then my colleague from radiation oncology will be covering the last part, which is radiation therapy. So what is active surveillance and how is it done? So active surveillance means there's no treatment. And we know this is safe because the risk of the cancer spreading in this context is very low, and the cancer to cause death is also extremely low. This is why it's a safe option for some patients, if recommended by your treating doctor. The protocol entails rectal examination and PSA every 3 to 6 months, so it's very closely monitored. We keep very close tabs on the disease. And after your original diagnosis, which is through a biopsy, a confirmatory biopsy is usually done 12 to 18 months afterwards. And then there may be more biopsies down the line if deemed necessary. There is an emerging role for MRI to assess the prostate and guide these biopsies. So the biopsy would help us target certain areas of the prostate if they look suspicious under the MRI. And here's an example. The MRI on the left side shows a normal prostate. However, the one on the right-hand side, where the red circle is, shows you an abnormal segment of the prostate. And the MRI would help us target this segment rather than randomly sample the prostate and potentially missing where the cancer is. So, for patients who opt to have active surveillance, when should it be stopped? If you have a rising PSA, if there is a change in the examination, if the repeat biopsy shows a higher grade group and occasionally higher volume of cancer, if there are findings that are suspicious on MRI, and if the patient chooses not to continue on active surveillance. Some patients find it a source of anxiety and stress to be under this close monitoring, or others find it very stressful to have a diagnosis of cancer without anything done for it. And this is absolutely okay to ask your treating doctor to offer you treatment for this. Moving on from active surveillance, we'll talk a little bit about surgery for the prostate. So there are 3 surgical options. There is open surgery, which is an open radical prostatectomy. There is robotic surgery, and there's laparoscopic surgery, or also known as keyhole surgery. They all share common features. They're all done under general anesthesia. They all require you to stay in hospital. And they all can have a nerve sparing if the tumor is not too large or not close to the edges of the prostate. As I mentioned earlier, occasionally we have patients with one-sided disease, and this gives us a chance to attempt to spare the nerves on the other side with no disease in it. And at this point, we don't have any evidence, any scientific evidence to say robotic surgery or open surgery is better than one another. They're both equivalent. And in these pictures, I'd like to show you what the incisions look like. On the left-hand side, the incision for an open surgery is anywhere from 8 to 10 centimeters, and it's usually low in your belly, below your belly button. And on the right-hand side, you see the robotic surgery incisions. These are 6 small incisions, about 1 to 1.5 centimeters each. So the total incisions in this case would equate to 6 to 8 centimeters. So very close to what open surgery offers. So you've had your surgery. What to expect after surgery? Hospital stay is usually 1 to 2 days. In fact, I would argue that the vast majority of our patients stay for 1 day, granted everything goes well with the surgery and the recovery. There will be some pain or discomfort after the surgery, but the vast majority of cases are very well controlled with over-the-counter pain killers. We very rarely offer stronger painkillers for this, just because patients generally don't need them. There will be a tube inside your bladder, which we call a catheter, and this is to drain urine from your bladder and also protects the suture line, which we use to bring your bladder and your urethra together. This tube stays 1 to 2 weeks. I'd say the vast majority of patients keep it for 7 to 10 days, and then we can safely take it out. And in terms of time off work, this entirely depends on what you do. If you're someone who has a physical job or a manual job, then we usually recommend 6 weeks off. to prevent any potential development of hernias. However, if you are someone who does a desk job, then 3 to 4 weeks is probably enough. I've had patients who went back in 2 weeks, but this will entirely depend on how you feel after the surgery and how your recovery is going. So as I said, the surgery is very well tolerated. The total recovery, including hospital stay and afterwards, when you go home, is anywhere from 4 to 8 weeks in most cases. Occasionally, you might still feel fatigued after this period, and this is normal. It applies to any surgery under general anesthetic. Some people feel it up to 6 months, this fatigue. Lymph nodes can be sampled during the surgery. This is only to check if the cancer has spread outside the prostate. The specimens that we take out are usually sent to the pathologist to be analyzed under the microscope. And removal of the cancer may have long-term benefits, not just short-term benefits. The short-term benefits obviously is a big psychological advantage, having your prostate cancer removed and treated. Long-term benefits are to prevent any potential spread of the disease or mortality, death from the disease. On occasions, depending on what the pathologists find, we may need to add a second line of treatment to ensure that the disease is controlled and does not come back. And other benefits to removing the prostate is men who have bother from their enlarged prostate, which causes them difficulty peeing. And in those cases, the removal of the prostate will probably result in them peeing a little bit better. And it's one of those few occasions where one surgery gets rid of 2 conditions at the same time. I'll briefly talk about the robotic prostatectomy or robotic surgery. As I mentioned, we use a robot, and this robot remains under the control of the surgeon throughout the procedure. It gives benefits, the instruments of it, and the visualization of it gives us an edge over open surgery. However, compared to the recovery, it rarely is 1 day shorter in terms of hospital stay, and there is some potential for earlier recovery of urine control. Very rarely you need transfusion after the surgery, and very rare that the bladder neck contracts or scars down, which can cause you bothersome peeing. Now, if we forget about open and robotic and keyhole surgery, we'll just talk about side effects or consequences, rather, of surgery of the prostate. Erectile dysfunction is a very big one. It depends on the age and the erectile function prior to the surgery, but the younger the patient and the better the function before surgery gives you a higher chance of recovery. Maximum problems are usually in the early phase after surgery, and it takes time to improve, but it does improve after over time. And it can take anywhere from 12 to 18 months for recovery to come back. If in the case that recovery does not become full, then there are options for treatment afterwards, which may require referring you to a different type of urologist that will be able to address this issue for you. Incontinence is another one. It's another consequence of the surgery. The vast majority of patients experience incontinence, especially during the first 3 months. It certainly improves over time, and we say usually it's fully recovered at 12 months. Very rare, about 1 in 10 men will still have a level of stress incontinence after a year, and total loss of urinary control is extremely rare. And if at that point there is either total loss or unsatisfactory recovery, there are things and treatments that can be offered afterwards, which would require you to see a specialist in this area. Blood transfusion after surgery, very rare. I mean, we're quoting 1 to 10% here, but it's probably much closer to the 1% than the 10. Bladder neck scarring, as I mentioned, can give slowing of the urinary stream, and it is very treatable after surgery. We'll just have to dilate it, and if that does not work, there are other lines of treatment afterwards which could fix the problem. Rectal injury is very, very rare. We mention it because of the close proximity of the prostate to the rectum, but it's extremely rare. It's probably in the range of 1%. And with this, I'll conclude my part of the talk. Please do not hesitate to ask any questions if you have any. And I will pass on the slides for my colleague in radiation oncology to continue with educating on radiation therapy in prostate cancer and what to expect. Thank you very much.
Hi, my name is Dr. Katie Jasper. I'll be talking to you a bit more about radiation and how that fits into prostate cancer care. So radiation works by damaging the DNA in tumor cells. When they go to try and divide, they don't have the ability to repair their DNA, so they'll die off. Fortunately, your normal cells can repair that damage, and when they go to divide, they divide normally. Major types of radiation that you'll hear about are external beam radiation therapy, also abbreviated as EBRT. You'll hear about brachytherapy, low dose rate brachytherapy or LDR, and high dose rate brachytherapy or HDR. You'll also hear about stereotactic body radiation therapy or SBRT. This is also abbreviated as SABR. So external beam radiation is the most common way that we deliver radiation. The radiation is developed and delivered by a linear accelerator or LINAC. It's this machine that you can see here. The patient is lying on a treatment bed here, and the machine would rotate around the patient and deliver radiation around the patient. These pictures down at the bottom here show how we've developed a radiation plan for different patients. So if you can imagine, this is a cross section of someone in their pelvis, like we've cut them like a loaf of bread. This red structure here is the prostate, and these areas to each side are the lymph node areas that would be at risk in this patient. So you can see that we've developed a radiation plan that treats these regions and avoids the bladder, which is just in front, and the rectum, which is just behind as much as possible. This other slice here would be a bit higher up, and it shows radiation covering lymph nodes regions a bit higher up. The process leading up to having radiation includes a CT scan done at BC Cancer. That CT scan is used for this treatment planning that you can see down below. And then you would start your treatment, which would be Monday to Friday daily treatments for a total of between 20 and 40 treatments. The difference here would be depending on your different risk factors, and it would be something that you would talk to your radiation oncologist in more detail about. Early side effects from radiation include a couple different things. It might be fatigue, just general body fatigue throughout radiation, especially towards the end. The areas that we're treating around the cancer will get a bit irritated, so that includes the bowel and the bladder. When your bowel gets irritated, you might have more loose stools and diarrhea. When the bladder gets irritated, you might feel like you need to pee a bit more frequently, or you have to get to the washroom quickly. We see everybody on treatment once a week to make sure that if you develop any of these symptoms, we can give you ways to help manage that. Down the line, there can be permanent changes in the way that your bladder and your bowels function. So that might be, for example, that you permanently feel like you need to pee a bit more frequently. Rectal bleeding is uncommon. Erectile dysfunction is common after radiation treatment. It's also common as men age. So when you put these two insults on top of each other, that's often something that people are dealing with down the line. Fortunately, the Prostate Cancer Support Center has some good resources for people going through prostate cancer treatment and dealing with some of the side effects down the line. Brachytherapy includes radioactive seeds that are implanted into the prostate. This is an example of a patient laying here, and we've sliced them through the middle like a book. And this is the rectum back here. You can see there's an ultrasound that's put into the rectum, so we can see the prostate very well when we're placing these needles into the prostate. The needles will be inserted, and then they'll release seeds throughout the prostate. This procedure is done under anesthesia, and the nice thing about it is a day procedure. So if you're just receiving brachytherapy, you can have all your treatment done that one day. People most frequently will go home that same day. You'll have a catheter in the bladder to help you drain the urine throughout the procedure, and then for a couple of hours afterwards. And then we'll make sure that you're peeing okay without that catheter before you go home. There's two types of brachytherapy, like I mentioned. LDR brachytherapy, which is the most common that's used in BC. That's just because we have a lot of expertise using this type of brachytherapy. You'll hear about HDR brachytherapy. It's just available in Kelowna right now on clinical trial. But different centers across Canada have different expertise varying between these two. So you might hear about HDR brachytherapy being used elsewhere. Both are very excellent options for treating prostate cancer. LDR brachytherapy, like I mentioned, will be depositing radioactive seeds into the prostate. So here's a picture here that you can see that there's many, many seeds that are left inside the prostate to deliver the radiation. This is another picture just showing the seeds being inserted into the prostate. The majority of the radiation is delivered within about 6 months after the procedure. And you do have to carry a wallet card throughout a couple of years just to make sure that there's no issues in the airport or at border crossings. Usually everything goes smoothly, as this is very common these days. HDR brachytherapy, the main difference between it and LDR is you don't have any seeds that are permanently implanted in the prostate. So we use a much higher radioactive source that goes through catheters into the prostate, will stay in the prostate for a predetermined amount of time, and then they'll come back out and they'll leave the area. So nothing is remaining in the prostate after you receive your radiation. So you're not radioactive for a period of time after this treatment. Side effects of brachytherapy are similar but a bit different still from external beam. So you might have a bit more urinary side effects in the short term after either type of brachytherapy. This once again would be urinary frequency, urgency, or discomfort. Like I mentioned, most people have a catheter for a couple hours after the procedure, but this should come out. Very rarely we need to leave that catheter in a bit longer just to help people pee. Urinary function can be permanently changed down the line from brachytherapy, but the risk of that is low. There's also a risk of things like a urethral stricture, which is a narrowing in the urethra that we'd have to get one of our urology colleagues to help us with to make sure that you're peeing okay. It can cause some bowel frequency or diarrhea, although this risk is usually a bit lower than external beam. And there is a small risk of rectal bleeding, which most often resolves on its own. A very low risk that people would need a surgery after having brachytherapy. Erectile dysfunction can occur after brachytherapy, similar to how it can occur after any treatment for prostate cancer. It might be a bit lower after having LDR brachytherapy than external beam radiation. But once again, age also plays a role in this. You'll hear about stereotactic body radiation or SBRT or SABR. This is basically a very focused type of external beam radiation where we're treating with a very high dose in a small area. The reason this isn't standard treatment for prostate cancer right now is we're still trying to learn whether it's okay to treat a part of the prostate rather than all of the prostate, which we think might be at risk. So that's why it's available on a clinical trial right now in BC. So if you're interested in doing this, just chat with your radiation oncologist a bit more about it. You'll hear about androgen deprivation therapy or ADT or hormonal therapy. What this does is it helps lower the testosterone in the body. The testosterone is the main driver for prostate cancer cell growth. So if you imagine we can lower that down, we lower that driver behind the cells growing. It also makes the radiation work a bit better. So we often use ADT alongside with radiation. It's given most often by an injection every couple months. And it itself has a bunch of different side effects that are different than radiation. There's a whole separate module through the Prostate Cancer Support Center that goes into ADT, the side effects, and how to manage these. So I encourage you to investigate that should you need ADT as part of your treatment. I know it can be very challenging to navigate all the different options for prostate cancer treatment. This is a table that kind of helps a little bit with that. So if you're in the low risk category, we often recommend a single modality. So that would include brachytherapy alone or external beam alone. If you're in that intermediate risk, if you're in the low category of that, we might once again just recommend a single modality. If you fit in the higher end of the intermediate risk, we may start to recommend 2 different modalities. So that might be hormonal treatment plus external beam radiation, or that might be external beam plus brachytherapy. When you fit into the high risk category, we often recommend multiple modalities. So that might be, for example, once again, external beam and hormone therapy, or it might be external beam, hormone therapy, and a brachytherapy boost. These are all things that you would discuss in more detail with your radiation oncologist.
Thank you, Dr. Almarzouq and Dr. Jasper, for those presentations. And so now that we've talked about the different treatment options available, I'll be talking about the different modules in our program and how they can help support you moving forward. So my job as the program coordinator is to assist patients in navigating the program and picking out the modules that are of interest to them based on individual needs and desires. We know that not all of our modules will be applicable to everybody all the time, so we let patients pick and choose the modules that are most applicable to them. And that's why we offer 7 different modules that address a variety of different topics that are relevant to prostate cancer patients. Most of our modules have both a group education session as well as a clinic. And so group education sessions are very similar to this, where we have a clinician talk about the topic and provide an overview of the information. And then for our clinic, you can meet with these clinicians one-on-one and receive more personalized care. And so we actually do require education sessions to be attended prior to attending a clinic. And the reason for this is once you receive sort of an overview of the information, it provides a really great foundation to go into your one-on-one clinic appointment. And in that appointment, you can spend a lot more time talking about your own personal medical history and receive more individualized care. We encourage partners and family members to attend any education session or clinic if they'd like to. And all of our modules are offered both in person or virtually. So you can access our clinic by coming in person, or you can also access it through virtual health or Zoom. And so these are the 7 different modules that we offer. So you're watching the first module right now. So I'll start by talking about the second module, which is our managing the impact of prostate cancer treatments on sexual function and intimacy. So as you heard from both of the physicians, regardless of what type of treatment you choose, there will be changes to sexual function. And so this module has an education session where our sexual health nurse talks about the sexual side effects of prostate cancer treatments, as well as options for dealing with them. And these different rehabilitation options go beyond the standard ED treatments such as Cialis or Viagra. And the goal of this module is to provide education, supportive care, options for different therapies to enhance sexual function, intimacy, and quality of life. We encourage partners to attend with the patient if the patient has one. And if you would like more support with this, you can access our sexual rehabilitation clinic, which is led by our sexual medicine physician and delivered by our sexual health clinicians or nurses. And there are 2 ways you can access our clinic. So the first is our in-person or virtual clinic, where you would attend the education session, and then you would have 7 face-to-face visits with our sexual health nurse to develop a rehabilitation plan that works best for you. And in this clinic, you'll also have access to personalized educational resources. Another option as well is something called the Share Clinic. And so this can be done in conjunction with the regular clinic, or it can be done on its own. And we've partnered with a group in Toronto called True North, and they've developed the Share Clinic, which is an online platform that patients can receive personalized education around changes to sexual function after prostate cancer treatment. They'll be able to message or converse with a healthcare professional or health coach for more support on this topic. And we encourage patients to access both our regular clinic and the shared clinic, as this is an enhancement to what we already offer, just to provide more education and support around sexual rehabilitation. So next is our lifestyle management module, which has two components, our exercise and our nutrition clinic. And so for the exercise clinic, we have a certified exercise physiologist who's trained in prostate cancer, and he delivers an education session all about the importance of exercise for prostate cancer patients. So including, what types of exercises you should be doing, how often you should be doing them, etc. And once you attend that education session, we would book you in for a one-on-one clinic appointment with him within about a month. And in that one-on-one appointment, you'll work with him to go over your medical history, take anthropometrics, do some tests, and he would develop a tailored exercise prescription just for you. And so this diagram here is just showing the different time points that you'd be attending our clinic. So you'd meet with our exercise physiologist over the course of a year at those different time points. And this is a really excellent module that we encourage all patients to take advantage of. It's almost like having a personal trainer for free. So I would strongly recommend all patients take advantage of this if they're interested in it. And the second half of this module is our lifestyle management nutrition clinic. And so we have an education session that's delivered by our registered dietitian, where they talk about nutrition for prostate cancer patients. So they'll talk about, the importance of a healthy diet, what a healthy diet looks like, and sort of talk about some, different things that you may have heard of on supplements, certain diets, things like that, and talk about, any myths that may be out there. We know that there's a lot of information out on the internet about different foods and supplements for cancer patients. So this is a really great session just to get some evidence-based information. And then if you are interested in having a one-on-one appointment with our registered dietitian, you can do that as well. And so if you meet with our RD, she can tailor healthy eating recommendations to your personal food preferences, and as well as address any health conditions that could be alleviated by changes in diet. So both the exercise and nutrition modules are excellent modules that you should be attending, as they really promote an overall good level of health and just provide a great foundation for your health moving forward. Our fourth module is managing the side effects of androgen deprivation therapy, otherwise known as ADT or hormone therapy. And so we have an education that talks all about the medications and how they work, what are some of the side effects, and how to manage them. We do know that the side effects of ADT are quite different than those you would find with surgery or radiation. So for example, some of the things may be hot flashes, weight gain, etc. But it's not to say that you would get all of them, but it's important to know what possible side effects there are so that you can recognize them if you are experiencing them. And so this session is delivered by our nurse or our nurse practitioner. And again, this session is for both patients and partners. And we also have an ADT clinic where you can meet with our nurse practitioner one-on-one, and he can help sort of address any side effects that you may be experiencing and ways to mitigate them. Our fifth module is pelvic floor physiotherapy for bladder concerns. And so we have a pelvic floor physiotherapist who is trained in male pelvic floor rehabilitation, present an education session all about Kegel exercises and how to make sure that you're utilizing them correctly to help with any incontinence that you may be experiencing after treatment. And so we recommend patients attend this module prior to treatment, just to get a better understanding of what Kegel exercises are and how to do them correctly. And then once you're about 12 weeks post-treatment, we do offer 3 complimentary one-on-one sessions with our physiotherapist. And so in these sessions, they can help manage any incontinence or bladder or bowel concerns that you may be having. So whether that's surgery or radiation that you've had as treatment, our physiotherapist can help address any of those concerns that you might have. And each of those sessions are individualized to meet each person's specific concerns and takes into account their medical history and what they're experiencing. So our sixth module is our counseling services. So we know that with a prostate cancer diagnosis, it can bring up difficult emotions such as loss of control, anger, and other distressing feelings. And you may also find that side effects from your treatment may impact how you feel about yourself, your identity, and your ability to undertake usual activities and roles. And so you can meet with our counselor and they can provide assistance addressing some of those emotions that you might be feeling, but they can also help address some practical concerns that may revolve around transportation to treatment, accommodation, financial resources, etc. And patients can meet with a counselor on their own. They can also bring their partner as well to meet with a counselor together. And partners can also meet with our counselor on their own if they would like as well. And so these sessions are, of course, complimentary, private, and confidential. And we encourage patients to take advantage of this at any point along their prostate cancer journey if they would like the support. So our seventh and final module is our metastatic disease management. And so this is an education session that's delivered by a medical oncologist or a nurse practitioner for patients who have been diagnosed with metastatic prostate cancer. So this education session talks about the different disease characteristics of metastatic prostate cancer and a natural history of metastatic prostate cancer. And the session will help patients become familiar with the different treatments available and the different medications, as well as some of their side effects and what to expect moving forward. So there are other treatments for localized prostate cancer that we didn't talk about today. So these therapies could include things like cryosurgery, HIFU or high intensity focused ultrasound, proton beam radiation therapy. And the reason that we don't talk about them in this session is because none of these treatments are covered by BC provincial health insurance, and they're often expensive out-of-pocket costs that you would have to travel out of province, if not out of country for. The second reason is that there's no long-term data at the moment to support that these treatments are superior or equal to surgery or radiation and the different techniques that were discussed today. However, if you are interested in any of these therapies, please talk to your physician about it. So how do we know whether or not the treatment is working? So when you meet with your doctor after treatment, they'll look at your PSA. And after surgery, your PSA should, in theory, be undetectable after about 6 to 8 weeks. And the reason for that is during surgery, they remove the prostate. And since the prostate is the only gland in the body that makes PSA, it should be undetectable after it's removed. After radiation therapy, the PSA doesn't usually reach an undetectable level immediately, and it may fall or go up and down over the course of months to 3 years after radiation. So for radiation, you still have the prostate in your body, and so the doctors have different thresholds of PSAs where they know is at a safe level. And of course, if you are experiencing any symptoms from your treatment, please bring them up with your doctor as well. So what if the cancer comes back after treatment? Some of these treatment options can be explored depending on what you've had as your initial treatment, the nature of the recurrence itself, and things like that. This is a conversation that you would have with your doctor to figure out what comes next. But these are just some of the options that you may hear. So there is salvage external beam radiation, salvage prostatectomy, androgen deprivation therapy, or hormone therapy that we talked about earlier. And there are some clinical trials as well for relapse. So the term salvage in those first two treatments simply just mean that they're happening after your primary treatment. So through the Vancouver Prostate Centre and BC Cancer, patients have access to clinical trials for all stages of prostate cancer. And it's really important to discuss the pros and cons of being in a clinical trial with your physicians, your family, your friends before agreeing to participate. And even if you decline to participate in a clinical trial, it will not affect your care moving forward. So please discuss what you've heard during this presentation with your family doctor, your urologist, and/or radiation oncologist. If you are interested in some more resources, here are 2 places you can start, the Vancouver Prostate Centre website, as well as the BC Cancer website. The BC Cancer website in particular has a lot of really excellent resources for patients, so I'd recommend checking out that. And of course, there are two patient query phone numbers that you could contact as well. If you are interested in getting some peer support or attending a support group, the Prostate Cancer Foundation of BC has all the information you need to find a support group in your area. So if you visit the website there or call that phone number, you can find a support group near you that you can attend and meet with other patients like yourself. And here are my contact details. If you have any questions about what you heard in this presentation today, please reach out via phone or email, and we'll be able to help you. Thank you so much for watching.